Hello and welcome to my peak presentation on the topic of temporal mandibular joint dysfunction. Today we'll be taking a bite into TMJD's identification, assessment, and management. Through a survey conducted on fourth-year students studying at La Trobe University, they expressed a need to have increased information about TMJ as they feel it was an important part which wasn't explored as much in their course of study. What I've gone through, according to the demands identified in this survey, is developed 3 videos. One of which is you're watching right now. We'll be discussing the anatomy and the biomechanics related to TMJ, and the second video will discuss the assessment in terms of subjective and objective for TMJ. And the last one will be management video for the most common presentations of TMJD. So now that we have all that out of the way, we will begin the presentation. What I want to make clear from the beginning is all images used in this presentations are being used under the 17 USC section 107, which will allow fair use for teaching purposes. So, what is TMJ? TMJ essentially stands for temporal mandibular joint and is basically formed by the articulation of the mandibular condyle and in the mandibular fossa of the zygomatic arch, and essentially responsible for jaw movements such as chewing, talking, and yawning. So don't worry about all the mandibular condyle and fossa and zygomatic arch. We will be discussing all that later on. The joint can be classified as a synovial joint, a condyloid type, complex, and with gliding movements. So it is a fairly complicated joint and is one of the most complicated joints of the human body. So it's very important that we spend some time understanding the anatomy and biomechanics of it. Now, TMJD, what is it? Essentially the D stands for dysfunction, and it's not one specific thing. It's actually a group of conditions characterized by pain in the jaw area and limited movement of the mandible itself. So that could be opening or closing. And TMJD may be caused by problems in the joint itself or muscles surrounding the joint too. So if you don't have a good grasp on the anatomy and biomechanics of the joint, it's going to be really hard for you to understand what exactly is going on. So let's spend some time talking about the anatomy and the biomechanics of it. Start off with the osteology, which is the bones of the TMJ. So what we have here is the mandible. So the mandible is this portion right along here. And then here you have your body of your mandible, then you have your angle of the mandible right along here, and then you have your ramus. Ramus serves as origin and insertions of many muscles that we will be discussing later. Then you have your TMJ joint itself, which is right over here, which is made up of the mandibular condyle sitting in the mandibular fossa. And another name for the mandibular fossa is your glenoid fossa. Okay, and in the front of that, the anterior portion of your ramus is called your coronoid process. Now above that is your zygomatic arch. It's very important. It's like the front part of your cheekbone essentially. The back part, good. You can feel it on yourself. And then I want to discuss a little bit further what I'm going to do now is zoom in on the TMJ joint itself. I'm going to talk about the mandibular condyle. So this is the mandibular condyle zoomed in. Right above that is the disc, the articular disc, and above that is your glenoid fossa, right in there. In front of it is the articular eminence, as mentioned before. It's a very important part of the structure, which plays a big role in how the joint actually moves or opens and closes, and we'll be touching base with that later on. In front of that you have your lateral pterygoid muscles, which we will discuss later as well. Um, Essentially, the head of the condylar, so mandibular condyle, is the point of articulation, and it's made up of fiber cartilage, which has specialized cells that produce synovial fluid, hence giving it the name of synovial joint. The lateral and the medial poles, so the outside and inside poles of the mandibular condyle, um, serve as connection sites for ligaments, which we will be discussing later. Let's go into the functional anatomy a little bit. And what I've done here is drawn this out for you, so just bear with me. I couldn't find a picture that would display the detail that I wanted to, so I went ahead and drew it out so I can break down everything for you. So just follow with me. We're going to start off with the articular disc. So the disc itself, as I mentioned before, is right up top here. What I've done is, in order to explain to you guys, it's broken up into 3 sections of the disc. Okay, so you have your anterior zone of the articular disc, which is thick anterior band. Then you have your intermediate zone of the articular disc, which is thinner, and there's a reason for that. It's because that's where all the action occurs and all the movement occurs. So from the rotation to the translation, which we will be discussing later. And then you have your posterior zone of your articular disc, which is also thicker than the intermediate. Yeah, and right behind the disc you have your retrodiscal laminae. So it's right along here. So you have your superior aspect, and then you have your inferior aspect. And the superior basically connects the disc to the joint capsule posteriorly. Now the joint capsule is this part right along here. Essentially what the joint capsule does is it encapsulates the joint, and it keeps the synovial fluid nice and tight in there. Now, so you have that. Then the inferior portion of the laminae, retrodiscal laminae, wraps around and attaches onto the condyle itself. Basically, the retrodiscal laminae, superior and inferior, help to stabilize the disc and keeps it from moving around out of control in the joint itself, because the alignment of the disc, as you'll realize later, plays a big role in the dysfunction of the joint. Okay, so we've discussed the joint capsule as well now. Now the next part I want to discuss, which we will be touching base with later as well, is the retrodiscal tissue, which is this point right along here. Essentially, it's very important as it's filled with blood vessels and nerves, and it can become a source of chronic pain. And it's one of the leading theories that where the pain comes from for people who experience chronic TMJ problems. Then in front we have the lateral pterygoid muscles. So you have your superior head and your inferior head. So I've drawn a thick dark line in between the superior and inferior, just for visual presentation, and just a minorly thicker line in the superior head, and that's there because with the superior head, the lateral pterygoid muscle, 40% of it, the top 40% of the fibers attach directly onto the disc themselves, and the 60% attach to the condyle itself. So just keep that in mind as we go along through this. Now the next part is the black spaces. So these black spaces right over here. So you have at the inferior and the superior. So these black spaces are filled with synovial fluid, and they're called the joint cavity. So superior joint cavity and inferior joint cavity. And they play a pretty important function as well. So essentially with movement. So just keep this in mind. The first part of jaw opening occurs in this inferior joint cavity right along here. And basically there's an articulation occurring between the mandibular condyle, the inferior surface of the articular disc, specifically the intermediate zone of the articular disc. As I mentioned before, is thinner, and that's where all the movements, rotation, and translation occurs. And then your superior, the superior joint cavity plays a role after the 25 millimeters of opening of the jaw. So the inferior joint cavity plays a role up to 25 millimeters of opening the jaw, and then after that point, after 25 millimeters to suppose 50 millimeters or 60 millimeters, the translation occurs, which involves the superior joint cavity and the articular eminence, which is right over here, which I said was very important, and the intermediate zone of the articular disc. Alright, so now that is all the way, I want to discuss a little bit about the biomechanics of the joint. So at rest, the mandibular condyle resting position articulates with the mandibular fossa, as we mentioned before, or the glenoid fossa. And when you open your jaw, the mandibular condyle does not stay in the fossa and rotate like that. It does to a certain degree, but it also there's a degree of translation occurring as well, which I will explain to you now. So as I mentioned, the inferior joint cavity rotation occurs for the first 25 millimeters. So first 25 millimeters, rotation of the mandible condyle. Then after 25 millimeters to full opening of the jaw, what happens is translation of the mandibular condyle down over the articular eminence. Now to explain this, I want to take a moment, and I've created a video for you which you can follow through, and hopefully it'll make more sense to you. So here you have your skull that I've cut out. So you have your rotation occurring at this point. So the first 25 millimeters, just a pure rotation. And then after 25 millimeters, if you want to open your jaw further, you have translation occurring right over the articular eminence. Just like so. And then when you want to close your jaw again, it slides back and rotates back. We'll be referring to this video again later on during the presentation. So let's return back over here. So now that we discussed a little bit on the functional anatomy and the biomechanics involved with the joint, I want to dive into the ligaments. The ligaments play a big role as well, and one of the ligaments we've already discussed is the joint capsule, which surrounds the TMJ from the neck of the condylar process to the temporal bone itself. Now, it's not shown over here. The joint capsule has been removed to reveal the lateral temporal mandibular ligament, which essentially is divides into two different portions. So you have your oblique portion and your horizontal / you can call it transverse portion as well. And essentially these two different fibers have different functions. So let's talk about the oblique fibers. Both of these fibers, the horizontal and oblique, attach onto the zygomatic arch, and that's where they start. Now the oblique fibers, these ones right over here, limit pure condyle rotation to 25 millimeters in the inferior joint cavity. So like I mentioned, remember, inferior joint cavity rotation 25 millimeters, right? And what they do is essentially wrap around the neck of the condyle. Now the horizontal portion of it essentially is, what it does is prevents any posterior gliding of the mandible itself. So if it's prevents it from going into the retrodiscal tissue. So if we go back into here, we have the retrodiscal tissue right over here, which I said before is highly vascular, and a lot of nerve innervation happens in over there. So if anything pushes in there, it's going to cause a lot of pain. Okay, so that's the horizontal portion. These fibers prevent the mandibular condyle from pushing back into there. Okay, and essentially these ligaments are pretty strong, and before they even give up, the condyle itself will break and before it squishes the retrodiscal tissue, so we don't have to worry about that. The other ones we need to know about is the lateral ligaments, which are also called the collateral ligaments. Essentially, just like the knee or the elbow, we have the ligaments that surround medially and laterally, and same thing over here. Essentially, at the TMJ, they stabilize the articular disc medially and laterally. Okay, and then we have the stylomandibular ligament, which is essentially the ligament back over here, extending from the styloid process all the way down to the mandible. And what it prevents from doing is limits excessive protrusion of the jaw, which is coming of the jaw forward, and just like a bulldog. And the last one is the spinomandibular ligament, which we don't have to worry about too much. There's no significant function that pertains to us as physios for that one, but it's right along here. Okay, so now that we covered the ligaments, let's dive into the muscles. So the main muscle over here, right along here, is the masseter muscle. It's a powerful elevator, meaning it clenches, brings the jaw up, and its secondary function is protrusion, which is bringing of the jaw forward, just like a bulldog. And because of its angle, how it's going, basically it starts off at the zygomatic arch and attaches onto the ramus, the angle, and a little bit of the body of the mandible as well, and it will wrap under inferiorly and wrap around with other muscles, which we will discuss later, which also function to elevate the jaw. And then we have our temporalis muscle right over here. Temporalis muscle wraps around all this area, starts off at the temporal fossa and inserts into the anterior coronoid process of the ramus, which we discussed earlier. And its action is essentially primarily to elevate the mandible, and secondary action, because of the fibers, the way they run, is retrusion of the mandible, so pulling of the mandible back. Alright, next muscles we're going to talk about is the medial and lateral pterygoid muscles. So the medial pterygoid muscle, what I've done here is gone and removed the masseter muscle, okay, and then I've also cut out the mandible itself to reveal. So this is the medial aspect of the mandible, and what it does is basically, remember I was telling you about the masseter muscle wrapping around and attaching onto another muscle? Well, this is the medial pterygoid muscle is what it attaches onto, and it creates like a sling around the jaw and around the angle of the mandible, and essentially its main action is elevation of the mandible as well, and secondary action, because of the fibers running like this, is protrusion, bringing of the jaw forward. Now the next muscle I'm going to be talking about is the lateral pterygoid muscle. This is a small but important muscle. I mentioned it twice already earlier. Essentially is broken down into superior and inferior portions, right? The superior portion, remember, 40% attaches onto the disc and 60% onto the condyle, and essentially it works to stabilize the condyle during mandibular loading, such as chewing. And then the inferior portion of the lateral pterygoid muscle is basically its action is to protrude the mandible, so bring it forward, as you can probably see, as well as a secondary action is to depress the mandible, so actually open your jaw. It's also responsible for lateral and medial movement, so turning to the side like so. So out of all the muscles so far, this is the lateral pterygoid muscle, the inferior lateral pterygoid muscle, is the only one that acts like a depressor. All the other ones act as elevators. Now, since we're talking about depressors, these are the other muscles that also act as depressors, which is the digastric muscle. So you have your posterior belly, which is right along here, and your anterior belly, which is right along here, and they act to open up the mouth along with the assistance of gravity. Alright, what I've gone ahead and done is created a table for you, so you can pause this at any time and have a read of all the muscles that we've been through, their origin, insertion, and their innervation and their action. So I'll give you a moment to pause. Alright, next slide. The last two muscles, remember the depressors, the digastric muscles. Same thing, origin, insertion, and innervation and action. So we'll pause there and you can have a read. Alright, so now that we've discussed the anatomy of the joint and a little bit of the biomechanics, I still want to discuss and go through and make sure that you understand what actually goes around in the joint. So at rest, right over here, number 1, essentially this is a picture of the normal function movement of the condyle and disc during the full range of opening and closing of the jaw. Alright, so 1 is at rest, and basically the apex of the condyle is right over the posterior band, and rotation will occur over the thin intermediate band as mentioned before. Now when the rotation starts happening, like I mentioned before, it only happens to the opening of 25 millimeters, pure rotation of the condyle and opening of the jaw within the mandibular fossa. However, it is hugging the anterior structure, so like so, is hugging the anterior structure of the articular eminence and preparing to go over the articular eminence due to the oblique ligament, which is preventing it from rotating greater than 25 millimeters as mentioned before. This is the point where if you try and open your mouth is where you get a little bit more increased resistance to open your mouth, and then after that, once you have that increased resistance, after that is writing, essentially translating the mandibular condyle over the articular eminence, and maximal opening is about 50 to 60 millimeters of openings, 5 to 6 centimeters, and translation essentially is complete with the condyle over the articular eminence as displayed in figure 5. And another thing to keep in mind is the condyle remains over the intermediate zone of the articular disc. Okay, it doesn't go behind or forward it. And then to close off the joint, same thing, the pattern is reversed, translation back into the glenoid fossa, and rotation occurs. And then you have your resting position. Good. What I'm going to do is play that again for you so you have a better understanding of what's going on. So you open up, rotation, pure rotation to 25 millimeters, opening, closing, opening again, just like so. And then when you want to open up further, more than 25, translation occurs over the articular eminence, just like so. So the disc isn't there, but the idea is there, and you can visualize how it happens. I hope this helped you out. Alright. Now we return. Now, things that you should know about the joint, just general points is the opening, again, maximal opening is about 50 to 60 millimeters, and functional opening is about 40 millimeters, 4 centimeters of the jaw. Closing obviously close packed, teeth against teeth. Retrusion is the going back of the jaw, so posterior translation of the condyles. And protrusion is 4 to 7 millimeters forward, like a bulldog, the anterior translation of the condyles. And lateral protrusion is essentially going side to side, and it's about 6 to 9 millimeters each way. And yeah, here are some definitions that you should be familiar with, which I have gone over through the presentation as well. Alright, well, that wraps up the anatomy and biomechanics of the TMJ. I hope to see you in the other videos, which will be followed up by this. In the next video, we'll be looking at the subjective and objective assessment of TMJ. Hope to see you there. Bye.